Thank you for watching today. We hope you enjoyed our webinar. At Iconotes, we're passionate about providing mental health professionals like you with the most clinically robust and intuitive mental health care software available. Thank you for joining us today for our webinar. Your commitment to advancing mental health care is truly inspiring. At Iconotes, we're passionate about providing mental health professionals like you with the most clinically robust and intuitive mental health care software available. From psychiatrists to therapists, nurse practitioners to social workers, Iconotes offers a comprehensive solution tailored to your practice's needs. With Iconotes, you can write a flawless note in less than 3 minutes, and without typing a single word. Iconotes was designed specifically to help mental health professionals write comprehensive notes quickly. Iconotes also provides a complete practice management solution with user-friendly scheduling, secure document management, HIPAA-compliant messaging, a certified patient portal, and more, so you can spend less time on paperwork and more time helping your patients. Try us free at iconotes.com/try-us.
Welcome, everyone. We're so glad you're here. Please let us know in the comments, in the chat, where you are joining us from. It's not even Monday. We're so glad you're here. Let us know in the chat where you're joining us from. And yeah, I seem to be all thumbs today, but I call mistakes messy and sexy. So I did have a messy, sexy mistake. How many of you caught that in the beginning? I played the wrong video. I'm so glad you guys are joining us. We got people from Arizona, Texas, Vancouver Island, Johnson City, Tennessee. Wow, Colorado. Welcome, welcome. We're so glad you're here. We have a great presentation in store from you. Someone from Chicago. I am right around the corner in Northwest Indiana. Thanks for joining, Brittany. Today we have a new guest that we've not had on any of our webinars before, and I'm really excited to introduce her to you today. So we have Rebecca Eyre, and she is going to be speaking to us about how to build an inclusive practice. So I'm really excited to share about her. She's a licensed mental health counselor, and she's a passionate advocate at the intersection of mental health and social justice. And as the CEO of Project Heal from 2020 to 2024, she became a leading expert on barriers to treatment access. And she brings to her work her personal lenses as white, cisgender, queer, able-bodied, neurodivergent, and she's an intersectional feminist and a longtime therapy client herself. And she practices from a trauma-informed, gender-affirming, anti-racist, sex-positive, and weight-inclusive perspective with deep consideration for marginalized identities and the impact of system oppression on individual and collective mental health. So welcome, Rebecca. You can come on stage. Thank you. It's great to have you, Rebecca, and I'm going to turn the stage over to you.
Amazing. Thank you. Thank you all so much for being here. I'm really excited about this, and I'm super passionate about this topic. Before we dive in, I am glad that she mentioned some of the identities that I bring to this, because I think it's a little odd when a white lady is talking about DEI. And so I just want to name that up front. I think one of the things that really informs my work is that I believe that it's really on me and people like me to do the hard work of actually implementing diversity, equity, and inclusion practices in spaces that we occupy. And so a big part of this for me as a therapist is that 75.6% of therapists are women. 83% of therapists are white. And I just found out today when I was prepping for this session that for the average employed therapist is 41 years old, and I'm 41 years old. So I do believe that it's on people like me to do this work and to listen to the people who are telling us how to do this work and to actually implement it in our practices. And so that does not mean I'm an expert on DEI at all, right? I've done a lot of the things and implemented a lot of the things that I'm going to be sharing with you today, but I'm still very much in practice myself. And so I just want to say that at the top here. So today we are going to be talking about what an inclusive therapy practice is and how to make our therapy practices more inclusive. So we're going to talk about the role of bias in our efforts to create diverse, equitable, and inclusive therapy practices. We're not going to deep dive into this. It's really going to be touching the surface of it, but understanding how much bias shows up in our work. We're going to explore some business models that make therapy both accessible for the client and sustainable for the therapist. This is a tricky balance that I think all of us struggle with. We're going to rethink some of our practice policies and spaces so that they work better for people across different identities and diagnoses. And then we're going to touch on compassionately adapting our go-to therapeutic modalities to better meet our clients where they are. There is going to be a point in the presentation where I'm going to ask you all to put in the chat some examples of things that you have done in various areas. And so when we get to that, I really want you to use the chat feature, please, because I'm going to be reading those things out. And in the meantime, please put any kind of questions you have. I'm going to try to save 15 minutes at the end to do Q&A. So I'd love to make sure that there's some questions in there for us to dive into. So there is a downloadable inclusivity guide with I put my kind of high level 15 tips in a downloadable PDF, which is on the handout tab in this platform. So let's start by thinking about common barriers to accessing care, because if we're talking about access, then we need to talk about what the actual barriers are. So some common barriers are financial, logistical, and cultural. And there's hundreds of these, but I think the most common ones are represented here. So in terms of financial, the average person in the United States simply cannot afford to pay for therapy out of pocket. And even some of the ways that we try to work around this, like offering sliding scale or super bills, can be inaccessible to some folks because it requires you to have a certain amount of money up front to either wait for reimbursement for your out-of-network benefits or even be able to afford sliding scale rates, which are, can add up, right, in terms of monthly cost. Around 1/3 of private practice therapists don't accept insurance. And I think it's important to understand how that impacts people who are trying to access therapy through their insurance. And of those people with insurance who have out-of-network benefits, around 29% of plans have out-of-network benefits, which means that 71% of insurance plans do not have out-of-network benefits. So the super bills aren't helpful for them. And for people who do submit super bills, around 50 to 80% of those costs end up getting reimbursed. And that's only after a deductible is met. So you can see how some of these workarounds continue to make therapy inaccessible to folks that don't have a lot of disposable income. Let's see. So there are some coverage limitations unless medical necessity can be demonstrated. I'm sure some of you who work with insurance have run into issues of service like reimbursement denials based on lack of medical necessity. And then even so, insurance plans that do, therapists that do take insurance, the reimbursement rates are really low. And that's one of the main reasons that a lot of folks don't accept insurance because it's not financially tenable. Logistical barriers include a lack of providers within driving distance. A lot of people faced this for many years before the pandemic. And so I think one of the coolest things about the only silver lining really of the pandemic is that we were able to figure out telehealth, which I think has been a real boon for creating access to care. But it still means that anybody who wants to do in-person therapy needs to live in an urban area or be very lucky. And there's other logistical travel barriers, even if you do happen to live near a provider. So there's also a lack of access to technology and or privacy that supports telehealth. So even with the benefits of telehealth, right, if you don't have a room that you can be in by yourself, or if you don't have reliable Wi-Fi, or if you don't have a laptop or a phone that works with the different platforms, it can be difficult for people to access even telehealth. And then physical spaces often don't accommodate certain client needs. So we're going to dive into some of those things a little bit later. But thinking about ADA accessibility, thinking about the furniture in the space, thinking about the restrooms, all of the kinds of things that show up in terms of being in a physical space. And then cultural, the lack of diversity among clinicians. As I mentioned before, the majority of therapists are white women. And so that means that there's a lack of representation in all of the other areas. There's also a lack of research that's inclusive of a broad spectrum of identities. I think it's really important to note that a lot of our care that's covered by insurance, that's evidence-based, that evidence that we're basing these protocols on are really tested on people with very limited identities. And we'll dive a little bit more into that as well. I skipped this one, but it's very important, and we'll get into this. Unaddressed or unnamed clinician bias. It's such an important thing. I think therapists like to think of ourselves as, neutral and impartial and objective. And at the end of the day, we are human beings. So we'll dive more into that. I think another way of thinking about the barriers is to think about all of the things that need to be true in order to access therapy. So a common profile of someone that is able to access therapy is that they can afford it. They either have access to financial means or they have quality insurance with minimal plan limitations. They have a flexible schedule or a consistent schedule, or they find a therapist who works outside of normal business hours, right? The scheduling can be a real barrier to the kind of care that people need. Social support outside of therapy. A lot of therapy assumes that people are going to lean on other people in between sessions to implement some of the things that are talked about in session. And there are lots of people, especially marginalized and multiply marginalized people, that don't have a robust social support system. And that can really be an impediment to actually making progress in therapy. Typical clients are neurotypical, meaning not neurodivergent. So they're better able to navigate the healthcare system. Think about how difficult it is to actually navigate all of the databases and search for a therapist and understand the filters that you need and to understand the lingo. And then being able to reliably communicate with providers, manage time, and follow treatment recommendations. A lot of things that are easier when you're neurotypical. When you're neurodivergent, there's a lot of other issues like time blindness and task completion and demand avoidance and lots of other things that make actually doing the things that you're supposed to do as a therapy client a little bit more difficult. In terms of people who are accessing therapy in person, they typically need to live in a urban or suburban area, have easy access to transportation, whether it's access to a car or access to public transportation. And they typically need to be able-bodied and able to physically access most spaces. And so in-person therapy has some of its own barriers that we'll get into. And then if someone is trying to access therapy via telehealth, they have access to a private space and reliable technology. So when you think about all of those things, money, flexible schedule, social support, neurotypical brain, ability to access spaces, right? This narrows and narrows and narrows the percentage of people who are easily able to access therapy in our current and traditional model. So let's talk a little bit about inclusive. So I think it's important when we talk about inclusivity to zoom out and think about the concepts of DEI. I know that lots of people have been engaged in DEI practices on their own. Maybe their practice has done some DEI trainings. Maybe you read a few books in 2020 when this was at the forefront of our cultural imagination. I think it's really, really important to continue doing DEI work, especially if you're a person with privileged identities or more dominant identities in terms of culture. This gets definitely a little bit, I want to be very, very clear that I'm not a DEI expert, but I'm a DEI student. And so I think my understanding of the letters in DEI, right? So DEI, so the D in DEI is diversity. So that is defined as acknowledging and celebrating the differences between people in terms of different identities and lived experiences like race, ethnicity, gender, sexual orientation, religion, socioeconomic status, body size, education level, language, etc. And a lot of times people, when they think about diversity, they think about representation. And that's the first place people start when they start doing DEI work, is like, who's here, who's not here? We need to make sure we have representation from different populations in order to ensure that this practice or this board or this staff team or this group of people is representative of the diversity and the people that we're trying to serve. And then we start thinking about equity. So equity is ensuring that everyone has equal access, taking into account their unique circumstances. And I want to take special care to differentiate between equity and equality. Equality equally distributes resources regardless of specific needs, and equity is about considering people's unique situations and distributing resources accordingly. And so in some ways, equity is actually not about equality. It's actually the disproportionate prioritization of people with more significant barriers. So a lot of times in DEI conversations and in DEI practices, people work on the diversity, they work on the equity. So they have people who are representative of different communities, and they have maybe lowered some barriers for folks who have lack of access, maybe, a different fee structure or a scholarship or whatever else might make that space accessible. But a lot of times we forget about the inclusion piece. And in my conversations and relationships with people who have marginalized identities or who are multiply marginalized, a lot of times they talk about feeling like they're brought into spaces for a diversity quota. They're maybe even given an equitable distribution of resources, money, time, et cetera. But the last thing that doesn't really happen is inclusion, which is about creating an environment where people feel considered, valued, and supported. And so a lot of times in spaces that really have focused mostly on diversity and not thought about the other, it ends up feeling tokenizing or exploitative, right? And we've heard this, I think, many times from people who are like, they wanted me there so that it looked better, but they weren't actually considering my experience. I didn't actually feel safe. I didn't actually feel known. I didn't actually feel valued. And so I think that the inclusivity piece is honestly one of the most difficult things to do, because it requires us to sort of have a mind for the other, especially those who don't have some of the same identities and lived experiences as us. So inclusive in this context actually means the aim is to embrace all people irrespective of identity or lived experience. I think inclusion is best understood in contrast to exclusion. So it's about giving equitable access and opportunities to all people and actively working against discrimination and intolerance and removing barriers. So an inclusive therapy practice, by this definition, is committed to providing accessible, affirming, and safe mental health care to as many different kinds of clients as possible. I think we can all easily get on board with the idea that we want to be an inclusive practice, especially if you're here. We care about people and we want everybody to feel safe, but there's actually things that we need to do to communicate our commitment to that inclusivity and to that safety. So let's talk about bias. I think when people think about bias, they typically think about explicit bias. So conscious, overt, negative, or limiting beliefs about groups of people. When we only think about explicit bias, basically, oh, I would never say that, or I would never think that, or, oh, no, that's other people. I don't have those beliefs. I think we really limit our self-understanding. And we really limit our ability to understand other people's experiences. I'm sure if we were in a room and I could ask for a show of hands, all of us have had a moment where we're like thinking that we're being really inclusive, and we're actually, people are saying they feel excluded, or they feel like they call out a bias of ours, and we're like, no way, that's not me, right? And that to me means that it's maybe not explicit, and it's not conscious, and it's not overt, but it's an implicit bias that we're not aware of that's showing up and more apparent to the people that we're trying to be inclusive of. And so I think if someone is telling you that they feel or detect or are experiencing some sort of bias or discrimination in your care, in your presence, in your relationship, I really encourage you to take it seriously, because it may be an area that you simply don't have a deeper awareness of yet. And a lot of times I think those implicit biases are the ones that they're sneaky and they're a little bit more insidious, and they can do the most harm because then they have the experience of feeling gaslit, right? Like, you're saying you don't have this bias, but I'm witnessing it, I'm experiencing it. And I think that can be a really damaging experience for a therapy client. So implicit bias is the subconscious and covert underlying beliefs, right? And they're more difficult to address because they're a lot slipperier. They typically correlate to common social attitudes. So a lot of times it's like implicit biases are informed by the water we're swimming in, right? If we have an ableist and fatphobic society, but you think you're not ableist and fatphobic, but you haven't done a lot of work to deliberately examine your ableism and your fat phobia, right? You're going to have ways it's showing up that you don't even think about. It also is correlated with some of our personal exposures and experiences. A lot of times we can have implicit biases against people or groups of people that we simply just don't have a lot of exposure to, or we have limited exposure to. And so we develop biases based on limited understanding, single incident things, or genuinely just ignorance, like not actually like having, like, if you only know one trans person or don't know any trans people, you're going to have some implicit bias to work through related to trans folks. Not only that, but like, even if you have 25 trans friends, right, you're going to still have some of those implicit biases to work through. So I think it's really important to think about who you've had personal exposures to, and to sort of think about what's missing from that, and to understand the ways in which the general milieu of our society may have covertly informed some of your assumptions. So I think our implicit biases are beliefs that we often are explicitly against, meaning we have this implicit bias, but, consciously we would never believe that we were somebody who had that belief, right? And so this can create a dissonance between our self-concept and the way we behave. I think it's very important at the base to just understand that every single person has biases, even clinicians. And if that's something that you prickle at or are resistant to, I really encourage you to go. There's at the end a resource list, and there's the Harvard implicit bias tests. And I really encourage you to take some of those tests, because even the things that you feel like you've done 10, 20 years of work deconstructing and confronting, you likely still have some implicit bias. And I think those tests do a very good job of revealing where our implicit biases lie. So in order to build an inclusive therapy practice, we have to build a practice that can support a diverse group of people, right? And what that means, because we don't have all of the identities, that means that we have to, by definition, be wholeheartedly prepared to work with people that are not like us. So how do we actually do that? Great question. Here's a list of some of the things. I think these are very high level ideas, but I know that these slides are downloadable, so I encourage you to do that. I really think it's important to begin with really considering your own identities and lived experiences. So understanding not only what your experiences are, which inform how you're treated in the world, but also thinking about how some of the things that you have experienced or have not experienced may shape your worldview. Also consider the identities and lived experiences of the people in your life. So like I was mentioning, if you have a really diverse group of friends or a really diverse city that you live in, right? Like, who is actually in your direct community? How much time are you actually spending with people who are different than you, or who hold different identities than you? And how do you talk about those things in those relationships? Are they addressed? Are they ignored? How do the people in your life who have different identities than you, that are less privileged than you in those identities, like, how do they actually feel talking to you about them? Do they trust you to have those conversations? If you're not having conversations about the different identities and lived experiences that you have with than the people that you're in community with, it's likely that those people don't feel safe enough to talk to you about it. And so I think I'd be really curious about that. I'm not saying we always get into like identity politics and, focusing on difference. I think relationship is built when we focus on our similarities and our commonalities, but I think it's also really, really important to understand the ways that differences show up and inform the way that we treat each other. Consider the identities and lived experiences that you have no first or even secondhand experience with. So people who you simply just don't have in your community and have had limited exposure to. Those are going to be areas that you may have the most learning to do in, but that doesn't mean that those are the only areas that you might have learning to do in. I would say in the areas where we hold dominant identities, so for me, being cisgender, being white, being middle class, being able-bodied, those are kinds of places where I hold a ton of privilege. So in the places where you hold dominant identities, you're responsible to listen to those with lived experiences, believe them first and foremost, and then deeply understand the impact and influence of our privilege in those relationships. So both intrapsychically, like in our relationship with ourselves, as well as relationally in the dynamic that we have with the people around us. In the areas where we hold marginalized identities, so for me, that's primarily being queer and being neurodivergent, we're responsible to understand the limitations of applying our experiences to others. So I don't know all of the things that are true for queer people all around the world at all, right? I don't think it's appropriate for me to like copy, paste, apply all any of my experiences as a queer person to say I understand all queer people, right? Or that I understand all neurodiversity. Sorry about that. So I think it's important to not treat any group of people, whether you're a member of that community or not, as a monolith, because it's simply not true. Where we have bias, we are responsible to do our research, get support, and deconstruct. So, once we're able to name and acknowledge and identify the places we have bias, we have work to do, right? We have books to read, we have conversations to have. And as much as possible, I really encourage anyone who's trying to work through some of their biases to find someone who specializes in that. And if they have the identity that you're actually working through, that can be especially helpful, but please pay them, right? I think it's really important that we're not asking anyone basically to teach us how to love them without compensating them very generously for that. There are some conversations that are easier to have, I think, with people who share your identities. And then there's other places I think that we're really responsible to go to the source and essentially anyone who's like made it their life's work to do that education, right? They want to teach, they want to improve our culture to make things safer for people that are in their community. And so find those people, pay those people, and continue to do the work outside of, a once annual mandatory DEI training provided for you. I think it's also really important to develop an intersectional understanding of privilege and oppression. Most of us have a combination of privileges and oppression. While the majority of therapists are women, right? Women are a historically marginalized population. So I may have some experiences as a woman that have been informed by my experiences of the patriarchy and toxic masculinity and all of those things. But I'm also in a field where I'm actually in the majority, right? And so we see a lot of that show up around men's mental health and around some of the stigma that men uniquely experience when trying to access therapy. So thinking about the ways that we actually hold different layers of privilege and oppression in all of the situations that we're in and understanding the ways that they impact each other. There's a link here and at the end of the presentation into Kimberly Crenshaw's model of intersectionality. And there's a lot of really, really important applications to think about there. So that's the section about bias. I'm telling you, I am really skimming the surface here. But let's dive into talking about money. So we know that most people would benefit from therapy, or at least I believe that. But we also know that most people can't afford therapy. as therapists, we often enter this field because we deeply care about helping others, right? We're in the helping profession. We are really interested in being of service, right? And helping people heal and being participants and supports to people as they do difficult things. But we also know that we need to make money to survive within capitalism. So I know that for myself, it's really, really difficult when I get an email from somebody who's like, I can only afford, $10 a session. Can I do therapy? And I'm like, I mean, I would love to. And like, I'm never going to be able to pay any of my bills if I say yes to every single person who asks me that, right? And so we're really walking a tightrope as therapists in private practice. And I think it's really difficult to find balance amid the tensions between wanting to help and needing to pay bills. And not only to pay bills, but to live a quality life and to feel comfortable. So I think some therapists try to help too many people for too little money, which leads to burnout. We see this a lot. And that's a lot of people who don't stay in the profession, right? And then there's others who focus on profitability, good for them, but they are maintaining the exclusivity of access to therapy. So my guess is that if you are here, that you're interested in trying to find a balance and not just to, be a celebrity therapist who accepts, only the richest of the rich, right? Let's talk a little bit about insurance. So this kind of combines us into talking about money when we think about building an accessible practice. So around a third of therapists in private practice do not accept insurance. Like I mentioned, insurance companies reimburse at much lower rates than we charge, around 40% less. Most insurance companies have prohibitive and laborious paneling processes. Give me an emoji if you have struggled with getting paneled at all of the documentation requirements, long wait times for reimbursements, limiting service coverage to clients with acute conditions that meet medical necessity criteria. There's issues when it comes to insurance. And most therapists in private practice don't have office managers or insurance and billing support staff, and it makes taking insurance really tough. That being said, I want to make a case for taking insurance. So I know, I'm sorry. It's a moderation proposal. I appreciate these emojis. So when I thought about how to build an equity-informed business plan for my practice, I started by thinking about how many direct client hours can I reasonably hold in a week. I would take into consideration admin time, CEs, clients seen biweekly, semi-weekly, clients with higher case management needs. And then from there, I would ask myself, how much money do I want or need to make in order to live comfortably and sustain my work? So we start getting into some math here. I know therapists love math. Then we think about, how many years of experience do we have? Do we have any specializations, which will help us be able to charge our private pay clients a little bit more? And then is there any commonly held or requested insurance plan in your state of licensure that has reasonable reimbursement rates? So the reason I propose thinking about finding just one insurance that you can get paneled with is that it helps build out the equity model that I personally use. It's not necessary, but it helps when we're thinking about inclusivity. So it's not a requirement, but it is part of the proposal that I'm going to show you when it comes to the equity-informed business plan that I've developed. So this is a really great visualization, which I'm not going to spend a lot of time on, that helps us think about sliding scale. And in my case, I think helps me think about how to distribute the spots that I have in my practice. And it outlines essentially the person, the jar that's full is someone who has plenty of financial resources. And I think the way that that's defined is very helpful, meaning that they have disposable income, they can, get their nails done or go on vacation or buy clothes when they want to and never, have reason to miss a bill or have money in savings or maybe own their home, right? There's some financial privilege there. That's a person who can afford to pay your full rate. The middle section is someone who has some financial access, but not a ton of financial access. And the jar that's nearly empty is someone who has extreme prohibitive financial barriers to disposable income and access to therapy. So this is a sample equity informed business plan that's basically mine, not exact, but round numbers and estimates. So when I was doing my own calculations, I thought I could do 26 client hours per week, which gives me 14 hours for admin time, CEs, case management, et cetera, et cetera. I see somebody raising their hand. Can you put the question in the Q&A, and I can get to it at the end? So I've divided my practice into thirds. So a third of my clients pay using their insurance because I'm paneled with Aetna in New York State, which reimburses at $130 an hour. A third of my clients pay a sliding scale rate. Some people pay much less than $150 an hour, but it balances out. And then those people are in, the category that's the most empty jar, right? Have extreme financial limitations or financial hardships. And then a third of my clients pay my full private pay rate. So balanced out, that affords me a decent living, right? And maybe even more than decent, right? And so but I also live in New York City. So that makes it definitely difficult. Yeah, I appreciate your comment. Sorry, I'm seeing a comment about getting hair and nails done as a part of basic hygiene. And I agree that is definitely something that varies across cultures. I think I'm thinking about some of my clients who are like taking a first-class flight to Fiji. Do you know what I'm saying? I definitely would never begrudge anybody the ability to go do self-care, things like that. That's definitely, I think, a variable thing. So this model essentially has it so that the people who are able to pay my private rate, which there are people who can pay the full private rate, there simply are, which is wild. I don't know what that's like, but that's amazing. And they basically it's an equitable distribution. So they sort of compensate for the lack of reimbursement that your sliding scale or your insurance paying clients make. And so sometimes this means having a higher private pay rate than you feel comfortable with, or that feels icky, where you're just like, can I really charge that much? And I really encourage you to think about people who have financial access and how that's really not a big deal to them, even though it's a big deal to you. So it's important not to project our own financial realities onto other people. For some people, $250 or $300 a session is manageable. That's wild. And for other people, they could never afford more than $50 a session, right? And so I think it's important for us to not assume anything about what people can do, and to essentially create space for some people who do have the means to actually offset some of the cost loss that comes from providing equitably accessible care. So ensuring access to your service, this has to do with the actual protocols and policies. So thinking about telehealth, using a HIPAA compliant video platform that's compatible with clients using an iPhone in case they don't have a laptop or access to a laptop, or they don't have a private place near their computer and they need to take their session from, their phone somewhere else that needs to be more mobile than a laptop. Consider using a platform with captioning technology is a really important practice for somebody who maybe is not an audio processor and is more of a visual processor and would have an easier time understanding what's being said if it's actually being something that they can read. Technology considerations. So on your website, thinking about text instead of images, or having text to voice options, or using alt text on all your images so that someone who may be visually impaired can actually interact with your website. Using contrasting colors and allowing for text resizing on your website is helpful for folks who are visually impaired or who are older adults or who are neurodivergent and have a difficult time reading certain things in certain ways. logistical considerations, I think making it as easy as possible for folks to actually remember your sessions and pay you. And that sometimes means working with folks who have a difficult time doing these sort of daily tasks and managing their time and remembering things. And I think historically in therapy, we've oftentimes pathologized like people who forget a session or who don't pay on time. And we think that they must not care that much or be that invested. And I think sometimes it's genuinely neurodivergence, right? So sending calendar invites for each session with the link to access a session, sending reminders prior to session. Sometimes all of that's automated depending on the platform you use. Considering flexible cancellation policies for certain people or having a certain degree of flexibility so that we're not essentially making it impossible for someone who is neurodivergent to be able to have a little bit of grace when they genuinely need it versus when they're just not taking it seriously. Considering options to accept cash or HSA payments. So these are ways that people have access to some money or maybe can maintain some of their privacy when it comes to paying for therapy. And then considering sending a payment reminder after a session so that you don't have to get into the psychodynamic conversations around, what does it mean that you didn't pay me on time, right? Some people just legit are busy and forget and have a lot going on and, don't have a brain that remembers things easily. So when it comes to thinking about the physical space for in-person therapy sessions, so the essentials are ADA compliance, thinking about like, could someone with a wheelchair access my space? Is there an elevator? Are there ramps? Are there railings, hand railings for people to support themselves in the bathroom? Are the doors wide enough for people of size or for people in wheelchairs? Gender neutral bathrooms are really, really helpful for people, obviously, who are non-binary or trans, but they're also just not a big deal. We have gender neutral bathrooms at our house. Why can't we have gender neutral bathrooms at home? Especially if you have a single stall situation. If you work in a building and they don't have gender neutral bathrooms, like you can talk to management. I think it's a helpful thing to consider whether a person can use their restroom safely at your space or to feel considered. Something very important to me as an eating disorder specialist who thinks a lot about weight stigma, weight-bearing furniture. So if you're buying furniture on some of these more affordable furniture sites, actually look at how much weight they can bear, right? A chair that has a weight limitation of 200 pounds is going to break in session with a person of a certain size. And so imagine how traumatizing it would be to literally break a chair in your therapy office, right? I think that I've seen that happen before in therapy settings where the furniture literally collapsed, and it was one of the most traumatizing experiences of that client's life, and it should have been a safe place for them to be. Also thinking about chairs with like larger seats and without arms to accommodate people of size. So really think about the furniture you have and whether it actually works for all bodies. And when it isn't possible to provide these essentials, maybe you didn't furnish your space, maybe your building manager doesn't want to do gender neutral bathrooms, maybe there is just simply not a way to make your building ADA accessible. I think it's important to notify clients about whatever the space limitations are in advance and then offer them an opportunity to discuss how it impacts them that they don't have these accommodations built in. Some other helpful things to consider for different kinds of clients in your space are to arrange the furniture so that the client's back isn't toward the exit or so that you are not between the client and the exit. This is something I've heard a lot from folks with trauma, that they think a lot about their position in the room and whether they have access to an exit. Having a clock that's visible to your clients. I feel like it's traditional to have a clock that you can only see, but that can create some anxiety for folks who are neurodivergent or have anxiety to not know what time it is and how much time they have left. And so giving them that offers them, I think, some empowerment. And then having amenities like fidgets, blankets, pillows, ice packs, essential oils, snacks, water, and a whiteboard. These are all things to think about when it comes to neurodivergence, different learning styles, people who may not have access to a snack or water or things like that in their environment. So just trying to make sure that people feel cared for in your space. Adjusting therapeutic strategies. I'm very aware of the time, and so I'm kind of going to start rushing through this. So as I mentioned, a lot of therapy modalities were based on research that was conducted on a narrow population. So majority white, cisgender, heterosexual, able-bodied, neurotypical, middle-class individuals. And a lot of times eligibility for research participation is limited to people who only have one diagnosis, so as to control as many variables as possible, but that doesn't help us understand how people with multiple diagnoses that interact with each other may actually be best treated. So I think it's important to think about adjusting our evidence-based modalities through an intersectional lens and to modify them to meet the unique needs of each client. A case example for this is that family-based therapy is known to be the most evidence-based form of treatment for adolescents with eating disorders. And you can imagine that someone who does not have supportive parents or does not live with an adult who has time to participate in their care, or who has food access or food scarcity issues and simply does not have enough money to buy the amount of groceries that they need in order to meet their meal plan. These are barriers to FBT actually being effective. And so if we actually modify that to meet the client where they're at, maybe they have another safe adult in their life, a coach, an uncle, a friend's parent supporting them, a school counselor, and maybe we find some additional food resources through a local food bank or a nonprofit that's focused on addressing food scarcity, supporting them with some of their food needs. So there's a concept called universal design, which I really encourage you to look into, but it essentially says, like, if you just design a space for the people who have the least amount of access, then you will design a space that works well for others, right? So as an able-bodied person, if I go into a space that has a ton of ADA accommodations, like, it doesn't hinder my ability to access the space to have all of those accommodations, but it does make that space accessible for someone with significant disabilities. And so the more accessible a space is for the most considered, underrepresented, most person with the most barriers, that space is going to that experience is going to be the most welcoming and truly inclusive for all of your clients. Being accessible to one does not make you less accessible to people who have general ease accessing things, if that makes sense. So I'd love to learn from each other. And I know we don't have a lot of time, so I'm going to just leave this up here. And I'm going to go to Q&A, but I'd love for you to put some of your answers to these questions in the chat. So I'd love to know, what are some of the things that you've done to work through your own biases? What are some money saving tricks that you use to keep your overhead costs down? What are some things you've tried to make taking insurance more financially and administratively viable? Like, I use Headway, which is a nuisance, but it's also, I think, easier maybe than doing it on my own, TBD. But that's the way that I have decided to be able to accept insurance, and it's workable enough for now. What are some ideas for making your services easier to access virtually? What are some of the ways you've made your physical space more welcoming to folks with different bodies or styles of processing or learning? How have you modified traditional therapeutic approaches to meet your clients' specific needs and life situations? And what or who have we missed? And so I think I really want people to put their ideas in here that I didn't touch on so that we can learn from each other, because I'm certainly not claiming to be, an end-all authority or having thought of everything. So I'm going to go to the Q&A now. Is equity really possible, considering that resources available to each individual is different and can be limited in some cases? I don't know that it's something that's achievable in reality, but it's more like a value. If you are familiar with acceptance and commitment therapy, there's a difference between a value and a goal. And so a goal is something that you could achieve or check off or accomplish, right? Fulfill. And a value is something that's a North Star, something you're always moving towards, something that is not attainable or accomplishable necessarily, but it's a guiding light, an orientation. And so I think equity as a value instead of as a goal is a lot more realistic. And so it's much more about, like, how equitable can we make it, not can we perfectly achieve equity. So you may discuss this later in the webinar, but I don't want to forget, how do you determine the sliding scale? Is it pay what you can, or do you actually ask them about their income? I ask because I was younger. When I was younger, I had a chiropractor who had pay what you can, but then spoke to me about how much I was paying because he felt like I wasn't paying enough. I don't want anyone to ever feel like I did. So I would like to know how it is addressed professionally and still be able to cover my overhead. This is a great question. I think having the jars visual, and maybe you can even modify it to your own, definitions on your website and at the beginning of your work with a person, and having a conversation at the onset about, here's what I typically do is I say, here's my standard rate. And then if they're like, I can't afford that, then I go, okay, what is an amount that you could afford that would be a stretch, but would not be a barrier? And so I kind of let them answer, and then I explain the different tiers, and I say sort of like, which category do you think you fall into? And I let them self-identify, and I do choose to trust them. And I think what happens for me is that if I say yes and enter into that rate with that person, then I accept that they may be at that rate for all time, right? And then you can sometimes put like a time limit on it. Like, okay, let's start here for the first 6 months. And then I'd like to revisit this and see if your financial situation has changed or if this is workable for you. And then you're the one who needs to bring it up again at the 6-month mark. And I know money can be really complicated to talk about. I think more than anything, it's about making sure that whatever you say yes to is something that you mean yes to, and being able and willing to say no if something truly does fall outside of the workability. And so a lot of times I'll be looking at it and it's like I said, my sliding scale like averages, 150. And that means I have a client that pays 50. I have a client that pays 75. And then that's offset by some people who pay, 185 or 175, right? And so as long as it averages out, that ends up being workable for me. And then I think it's important to work through feelings that come up for us with our clinical supervisor. If we start feeling like resentment around how much we're accepting or how much we said yes to, or if we're noticing that someone, self-identified as being in a much more strained financial place, and then they end up coming in and being like, I got this Gucci handbag, and I don't know, just got like, I get Botox every 2 months. I mean, whatever the case may be, you can decide what things feel like the things that are evidence of disposable income. And I think working with those feelings you have that come up, and maybe even having conversations about them. But it's something I think that it's more important to sort of actually really mindfully consent when we are offering sliding scale rates. And if you need more information to validate it, I don't think there's any issue with doing that. I don't know if you can ask specifically about income, but I think you can say things like, do you rent or own? Do you have an over X amount in savings, that kind of thing, and kind of set your own standards for how you evaluate. As much transparency as you can have, I think the better, because the more you put on your website of like, here are the questions, or on your intake forms, like, here are the questions I need to determine what your sliding scale rate will be. Like, I think being really transparent about like, in order to accept a client as sliding scale, I need XYZ thing to be true. And go from there. Okay, so I want to go back to learning from each other and look in the chat. Okay, I'm not seeing a lot of responses. Someone said attend various trainings to expand my mind. Yeah, I definitely think trainings are crucial. I think with the example given, they may have some implicit bias. Like if you have a luxury car and nice clothes, but fewer pieces, or do your hair daily, or they assume you have more than someone who comes dressed in sweats, I think this can be a hard thing. So some people have Gucci bags from family, but you can't ask for money to come to the therapist, especially in domestic violence or financial abuse situations. I agree with this. Just some things I have seen. Some people do have a financial disclosure policy before they do a sliding fee scale, but it can be a barrier if you are in debt or have another issue. This is why I totally agree with all of these caveats. And this is exactly what I mean by like having as much transparency and open communication as you can, because I agree there are some people who have very valid reasons that they can't access the money that they may on paper have access to, which is why I don't think that, copies of bank statements is always like the best evaluation of someone's financial access, right? And I think that asking somebody to be honest about essentially how much people are willing to sort of share about what their current financial situation is. I think there are some outward signs that are not visual cues or about like purchases, right? If someone is on Medicaid, right, they had to prove to the government that they were low income. If someone has food stamps or is on SSDI, right? Like there's certain things where you actually have paperwork to demonstrate some of this. So those are some of the things that you could consider. I mean, maybe you reserve your sliding scale spots. Maybe you have a smaller percentage of your sliding scale spots and they're very, very low sliding scale spots and are compensated by the majority of your other clients. And the requirements for having one of those spots is a higher threshold where they are actually showing demonstrated need for government assistance based on income. Regarding biases, reading a lot, amen, listening to queer, trans, Black, Indigenous, and people of color who have been paid for their labor, learning about my privilege. Exactly. I'm so glad that you're sharing that, Hope. That's a lot of the behind the scenes work regarding bias. And it's ongoing. It can't be treated like a fad diet or, a book of the month club. It needs to be years and years and years, like an entire life posture. Upper middle class and those raised above were taught never to talk about money. You can be embarrassed but they would have insurance and wouldn't allow you to see you unless self-pay due to restrictions. Sorry, that's a little jumbled, but yeah, some people are uncomfortable talking about money, but I think that it's important as therapists, especially at the consultation call, at the initial consultation call, that we have an open and honest conversation about money, because you're entering into a business agreement. You're providing a service, they're paying you. You both need to consent to the transactions ahead, right? So the more open and honest and naming how uncomfortable it is, I think the better. More welcoming space, having floor cushions, blankets, fidget toys, ensuring to verbally make space for noise canceling headphones, loop earplugs, etc. Yeah, a lot of folks with sensory processing issues need some of those external things. I always start my sessions by like making sure that they have everything that they need, offering them water, offering them a snack, offering them a fidget, asking if the temperature's okay, asking if the light's okay, asking if they need anything. Not everyone immediately knows what they need, but some folks do. And I think having them check in, being mindful about lighting, very much so. Those overhead lights, the big lights. I think these are some really great considerations. So I think what we're really thinking about is like, can they actually access your services? Do they feel safe and comfortable in the space? Do they have the resources that they need in order to benefit from your care? Are there ways in which you can make it less rigid or adjust some of your policies specific to the person? Thinking about the actual work that you're doing, and if something isn't working for someone, or they don't have something that they need in order to benefit from therapy. Like, I think it's our job to try to meet them where they are and find ways to accommodate. I think as long as we have a posture of like, how can I remove barriers? And how can I be honest about the ways in which I'm not the right fit for some clients? If I am actively working on, my racial bias, if I just figured out that I have white privilege, 2 minutes ago, I should not be working with clients of color probably until I've done a little bit more work and learned a little bit more. So I think there's some honesty that we really need to have with ourselves about who actually will be safe in our space, who actually can access our care, who are we actually ready to work with, how flexible can we be in our accommodations, and make sure that we're able to do well by the people who actually do come into the space that we're offering. Yeah, I think that's a great note to end on. And I know we're at time. So thank you all so much for being here and for having this conversation. I know that money, bias, all of this stuff is not everybody's favorite conversation, but it's really important for us to think about because these are the things that are standing in the way of people getting access to the care that they need. So there's some additional resources for learning. And I think that Angela is going to play a video now. Thank you all so much for being here.
Thank you for watching today. We hope you enjoyed our webinar. At Accommodations, we're passionate about providing mental health professionals like you with the most clinically robust and intuitive mental health care software available. From psychiatrists to therapists, nurse practitioners to social workers, Accommodations offers a comprehensive solution tailored to your practice's needs. With Accommodations, you can write a flawless note in less than 3 minutes, and without typing a single word. Accommodations was designed specifically to help mental health professionals write comprehensive notes quickly. Accommodations also provides a complete practice management solution with user-friendly scheduling, secure document management, HIPAA-compliant messaging, a certified patient portal, and more, so you can spend less time on paperwork and more time helping your patients. Try us free at accommodations.com/try-us.